Hello, everybody. Warm welcome. Good morning. Hi, everyone. How are you doing? A quick nod if I'm audible and visible for all of you. So then we'll be good to go for today's session. Yes, a quick confirmation from everybody. Is it audible? Is it visible? Is the AV quality good? Hi, success. Good morning. Hi, Sri Aruna. Hello. Hello. Good morning. Am I audible and visible? Hi, Sri Aruna. Hello. Hello. Good morning. All right. All right. All right. So I've got the confirmation here. Thank you for that confirmation, guys. I hope everybody is doing good. And today is the festival of Sankranti, right? Pongal, Sankranti, Lohri, that we call it. Yes, everywhere everybody is celebrating. Yes, we will also celebrate, but after a quick session of 1 hour of anesthesia. All right. So thank you all for joining in, guys. Today we'll be doing a much needed session in anesthesia from the perspective of your upcoming FMGE examination. All right. So welcome all. Yes, Shri Aruna, we do celebrate. I mean, we just fly kites and all in Gujarat here. That's what we'll be doing after my daughter wakes up. Yeah, she's back. Good morning, Revti. All right, chalo. Alia, good morning. Okay, so everybody is here. So we are going to start with a much needed session. But before we start, there are some announcement that Unacademy has come up with Neat PG Vitals, in which you will get live plus recorded, right? Best of both the worlds that we call it, right? Unacademy Vitals, in which we have got recorded sessions for all of you guys. 12 subjects are already live. 3 subjects are going live this month, and anesthesia will be going live from next month onwards. All right, so make sure you subscribe to this Neat PG Vitals for the Unacademy platform, because you will get best of both the worlds, the recorded as well as the live classes. All right, and also there is this rankers batch in which top 5 educators from Unacademy will be coming up and taking up all your last year's TND. Everything will be covered in this rankers batch, right? 2 months for your NEET PG preparation. Also, there is this Unacademy notes, right, which are there. If you subscribe to this NEET PG Vitals, you'll get it free of cost. है ना? So there are lots of offers coming up your way. And also from 20th of January, that is from next week onwards, there will be a dedicated 2 months batch for revision of all the 19 subjects. Yes, and it will be covering around like 5 to 10 hours per subject, and it will be a quick fire revision sort of thing, right? High yield MCQs, all the practice, TND, image based question, PYQ, everything will be included, right? So lot of things coming up for your last minute revision from next month onwards. All right, and this is a free all India mock test that we have on 22nd of January, which will start at 9 a.m. next Sunday, right? From 9 a.m. onwards, you will have this free mock test which will be there all over India. So this is a quick way to assess your preparation and to see where do you stand, right? More than 50,000 students would be taking this test. So to subscribe to any of the plan, you can use the code Dr. Hitesh. So let us start, guys. Everybody, give me a quick nod in the comment section. All of you are here. Yes, Revati, Sri Aruna, Alia, success. Let us start with the MCQs for your upcoming NEET PG examination, everyone. All right. Chalo. The first question on your way, and every question will be poll based. For every question, there will be single best answers, right? So you have to give your answers in the comment section, and I'll give you around 30 to 45 seconds for every question, right? Which of the following is IV hypnotic agent? Sevoflurane, halothane, desflurane, fentanyl, tramadol, buprenorphine, propofol, thiopentone, etomidate, clonidine, dexmed, or adenosine. Which of the following is IV hypnotic agent? Success says C. Alia, Revati, Sanjay, yes. Go on, guys, go on. Be quick, all right? So this will be a rapid fire, quick fire MCQ session when it comes to anesthesia. First of all, what it is asking? It is asking IV, right? An IV hypnotic agent. Hypnotic means which will sedate you, which will make you unconscious, right? So automatically option A is ruled out. Why? Because option A is what? It is inhalational anesthetic, right? They are not IV. Got it? What is option B consisting of? It is consisting of fentanyl, tramadol, and buprenorphine. What are these guys? These are opioids, right? Opioids are usually used for analgesics. Opioids are usually used as analgesics, right? Exactly correct. Very good. What about propofol, thiopentone, etomidate? Propofol, thiopentone, etomidate. They are IV induction anesthetics, right? Or IV induction agents, right? So these are the drugs which will cause or which will be included in your IV hypnotic agents, right? They will make you unconscious. They will make you knock off. So correct answer here is propofol, thiopentone, and etomidate. What about clonidine, dexmed? Yes. Which class of drug do they belong to? Clonidine, dexmedetomidine. Alpha 2 agonist, right? They are alpha 2 agonist. That means they are used as an adjuvant to anesthetics. They are not the sole anesthetic. They are used as an adjuvant, right? They are used as an addition to your anesthetic agents, right? They are not used as a sole anesthetic, right? They are used to prolong the duration. They are used to make the patient go into that conscious sedation state with the help of dexmedetomidine to tolerate the tube. In the regional anesthesia, if you want some patient to lie down peacefully, that conscious sedation state, that is where we use dexmedetomidine. Clear, everybody? So correct answer to this question is propofol, thiopentone, and etomidate. All right. Next question. Identify whether this is Burp classification, BURP, whether this is Wilson score, whether this is Cormack-Lehane classification, or whether it is Mallampati. Very good. Very good. Yes, this is a classical question which was asked in December of 2022, right? This was a question which was asked in December of 2022, right? So therefore, whenever you are studying, whenever you are preparing for your FMG examination, remember to see previous year's question as well as the previous year's topic, right? So what is it? In this, you can see the image of a mouth open with the trunk protruding out, right? This is a classical picture of your Mallampati classification, option D, right? You can see it is class 1, 2, 3 and 4. There are 4 classes of Mallampati, right? 4 classes. So class 1 consists of what? What all are the structures that is visible? In the comment section quick. Whenever we see class 1, whenever we talk about class 1, what all are the structures visible? Yes, it is hard palate, soft palate, uvula and tonsillar pillars, right? Class 2 consists of what? Hard palate, soft palate. It is just the base of uvula that you are able to see. Tonsillar pillars is not seen, right? What about class 3? Only hard palate and soft palate is seen. You are not able to visualize uvula or tonsillar pillars. And class 4 consists of, you are able to see only hard palate, right? So the more is the classification, that is grade 3 and grade 4, the greater would be the difficulty of intubation, right? It assesses the difficulty of intubation, right? So these are your structures that you are able to see, right? And as and when the grade progresses, the structures become less and less visible and the tongue size goes on increasing. It is because of the large tongue as compared to your oral cavity that you are not able to see, right? And this is a typical of difficulty of intubation, right? Difficulty of intubation. Which other classification here tells you about difficulty of intubation? Yes, in the comment section. Which other classification here tells you about difficulty of intubation? Yes, Cormack-Lehane classification, right? Yes, CL, that is Cormack-Lehane classification. This is when you're performing laryngoscopy, that time you will be able to see the cords, not glottic opening. Yes, no, only epiglottis is visible. Depending upon that, you actually tell what is the class. CL kitna hai, what is the Cormack-Lehane classification or grade. All right, moving on to the next question. Identify. Identify. What is this image depicting? Yes, whether it's a nebulizer, whether this is face mask, whether this is high flow nasal cannula, or whether this is Venturi mask, right? Identify. All of you have given correct answers so far. Yes, this is a Venturi mask, right? This is a Venturi mask. You are able to see this image here with different colors. You are able to see this is a typical Venturi mask that you are able to see, right? Face mask along with a Venturi, right? Why this is so? Let us move on to the next question and then you'll be able to answer this better. What is the principle which is used in Venturi mask, right? Venturi principle. What is Venturi principle? It is based upon Fick's principle. It is based upon Bernoulli's law. It is based upon Hagen-Poiseuille equation, or is it based on Reynolds law or Reynolds principle? Yes. Which principle is used in Venturi mask? This is a previous year question, guys. Okay, I am telling you, this is a straightforward previous year's question which was asked. Option B is what Success and Rachna says. Yes. Other people, try out whatever it is, right? Today if you try out, tomorrow you will not fail, right? Exactly correct. This is based upon Bernoulli's, right? Venturi is based upon Bernoulli's principle. Now if you see, guys, there is this narrowing of your pipe, right? When you see a water coming through this pipe and when you see a water coming through this pipe, right? If you take it like this, what will be the pressure here in this pipe, the larger pipe, and what will be the pressure here in this small pipe, right? The pressure will increase or decrease in smaller one. Yes, the pressure will increase here, right? Whereas the pressure is less as compared to the smaller pipe in the larger pipe. Same thing happens with air as well, right? So whenever the air or oxygen which is coming from this pipe, suddenly you see that it narrows, right? Suddenly you see that it narrows here, right? So what is happening when it narrows? The air entrapment happens, that is the outside air is also sucked in little bit here, right? But one very important thing here is that with respect to your flow rate, right, with respect to your flow rate, FiO2 is constant, right? If you want to deliver 30% oxygen, if you want to deliver 40%, if you want to deliver 60% O2, this different Venturi's mask, that is the end with color coding that you are able to see, you will be able to use it, right? So therefore Venturi mask is a fixed FiO2. It delivers fixed FiO2, that is whatever you want you can deliver that. Clear? Yes. So if the pressure increases, there is entrapment which happens, which will help you in properly diluting as the FiO2 what you want will be delivered to the patient. Alright? Okay. Whereas with face mask, you will see it is a variable FiO2, right? Whatever is the fraction of inspired oxygen, right now we are breathing oxygen at room air, that is around 20-21%, right? But if you want to deliver 30%, you can use Venturi mask. But if it is variable from 24 to 44, whatever, you can use face mask. Got the difference, everybody? Give me a quick nod so that we are able to move on to the next question. All right. Next question on your screen. Which of the following layer is not pierced, or rather it should be, what is the correct manner in which the following procedure is being performed, right? The layers which are being pierced, right? Which is the correct sequence in which the following procedure is being performed and which layers are pierced? Write down in the comment section the answer for this. Is it syn, subcut, supraspinous, interspinous, ligamentum flavum, syn, subcut, supraspinous, interspinous, ligamentum flavum and dura mater, syn, subcut, ligamentum flavum, then comes your supraspinous and interspinous ligament, or it is skin, subcut, supraspinous, interspinous and then intervertebral disc, right? What is the sequence in which the layers are pierced, right? Give a correct sequence. Correct sequence in which the layers are pierced during the following procedure. First, write down in the comment section what is the procedure being performed, right? Then your mind will be clear. What is the procedure that is being performed here, guys? Yes, this is nothing but epidural procedure, right? Epidural anesthesia. Exactly correct, Revati. Success. This is a Tuhi's needle. You are able to see markings here, right? And with the flange that the anesthetist is holding the needle, right? So this is a Tuhi's needle in which we are performing the epidural procedure. So what are the ligaments or what are the structures which are pierced anatomically? Skin, right? Then subcutaneous tissue, then comes your supraspinous ligament, interspinous ligament, yes, supraspinous ligament, interspinous ligament, then comes your very important ligament, that is ligamentum flavum, right? Then comes your dura mater, right? Then comes your arachnoid mater, pia mater, and then the spinal cord, right? So this is how we go about with the structures being pierced, right? This is the anatomical thing, right? So what is the procedure here? It is epidural. Epi means above, right? So epidural procedure is being performed. That means this is the area that is being pierced, or this is the layer that is being pierced. So which are the structures which will be pierced here for performing epidural anesthesia? Skin, subcutaneous tissue, supraspinous ligament, interspinous ligamentum, ligamentum flavum. These are the structures in the following order which are being pierced, right? So skin, subcute, supra and interspinous ligament, and ligamentum flavum, right? And what is the technique that we call it? We call it as loss of resistance. We call the technique as loss of resistance. Clear, everyone? Now if the same question, if I say, if I am performing lumbar puncture, right? If I am performing lumbar puncture, that is your spinal anesthesia, or we call it as subarachnoid block, right? Where will we go? Sub means below, so this is the area for your subarachnoid block, below the arachnoid membrane. Yes, and what is the endpoint here? You get a free flow of CSF, right? This is the endpoint. You get a free flow of CSF. Clear, everybody, so far? Any doubt? So what is the correct answer here? Skin, subcutaneous tissue or subcutaneous fascia, supraspinous, interspinous ligamentum, ligamentum flavum. Oh, correct answer is option A, right? If you see in rest of the answer, dura mater for this is not pierced, right? The ligamentum flavum is the last ligament, not the interspinous, right? And your intervertebral disc comes directly there, right? It is not the last one. Clear, everybody? Yes, intervertebral disc nowhere comes in picture. So correct answer to this question is option A. Alright. So also along with this epidural, yes, last year in INICET, I believe, a question was asked on lumbar puncture as well, right? Lumbar puncture as well. So whenever you are reading regional anesthesia, yes, whenever you are reading regional anesthesia, be sure that subarachnoid block and epidural, that is your spinal and epidural, is read with thoroughly. You know the differences, you know the contrasting features, as well as you know which is preferred where, right? These are the things that you have to read thoroughly when you are reading the regional anesthesia. Alright? So therefore we say previous year's topics are more important than previous year questions. Alright, from questions you come to topic as well. Next question on your screen, guys. Come on, be quick. A patient of COVID-19 requires oxygen therapy. Which of the following cylinders should be used to provide oxygen? Blue, black body with white shoulder, brown or grey colored cylinder? Yes, a quick forward easy question, but it has been asked. And if you see, since last 3 years, COVID-19 question has been asked at least thrice. right? In every exam it has been asked at least once or twice, right? Exactly correct. It is like your Unacademy t-shirt, right? Black body with white shoulders, black body with white shoulders. That is your oxygen. Let us have a look at some of the cylinders here. Identify the cylinder, guys. Identify the cylinder. This is a blue colored cylinder, right? Blue colored cylinder. What gas or what cylinder it is? Yes. ब्लू एन नीला ब्लू को हिंदी में भी कॉल इट एज नीला ब्लू कलर इज नोन एज नीला इन हिंदी राइट सो नीला एन starts with N so it is N2O nitrous oxide clear everybody yes what is the pin index of nitrous oxide what is the pin index of nitrous oxide next question 25 15 35 26 16 yes how do we remember the pin index that table should be there in your mind clearly right 2 atoms of nitrogen 2 atom of nitrogen 1 atom of oxygen so total 3 atoms combine to form nitrous oxide right so 3 5 is the pin index of nitrous oxide whether this is present in the form of gas or liquid whether this is present in the form of gas or liquid guys in the comment section yes 2 5 is oxygen that is correct 3 5 is nitrous oxide whether this is present in the form of gas or liquid this is present in the form of liquid right it is present in the form of liquid so what will be the pressures 750 psi what will be the pressure it will be 750 psi pounds per square inch all right next cylinder identify yes this is a gray colored cylinder yes gray colored cylinder so which gas is it containing gray colored which is the gas which is present in gray colored cylinder in the comment section guys whenever we want to write G how do we write we first write C right so G लिखना है so first write C and then we have to make it a G so CO2 right it contains carbon dioxide yes gray colored cylinder is of carbon dioxide exactly correct pin index of carbon dioxide pin index of carbon dioxide pin index remember our trick any gas which start with C will have 6 in them right any gas which start with C will have 6 in them to write 6 we need to write C first and then make it a round right to write 6 we need to write C first then make it a round right so carbon dioxide start with C so what is the pin index 1626 right everybody 16 and 26 everybody knows that chart that we have made yes for pin indexes everyone next one next cylinder this is black body with white shoulders right black body with white shoulders black and white black body with white shoulders oh, nice yes Revati success so just go back to that chart that we had made and answer the questions so this is a cylinder of oxygen remember oxygen everywhere we have spoken with the trick of the chemical formula O2 right it is two colored cylinder so it is black body and white shoulders black body and white shoulders right black body and white shoulders two colored cylinder 2 stands for pin index 2 5 oxygen pin index of oxygen is 2 5 right yes 2 atoms 2 colored 2 5 is the pin index next comes again with your 2 what is the pressure inside this cylinder right how much is the pressure it is again starting from 2000 psi right and it is present in the form of gas it is not present in the form of liquid it is present in the form of gas all right clear yes pin index of Antonov chalo a quick revision which is the first gas what is the pin index of air write down in the comment section 4 5 and 6 that is how we have studied right in the table of 4 5 and 6 first gas is air so what is the pin index of air what is the pin index of air? 1 5, exactly correct. O2, right? 2. So it is 2 5 under the table 5, right? Then comes your nitrous oxide, 2 atoms of nitrogen, 1 atom of oxygen, total 3 atoms combined to form nitrous oxide. 3 5, right? Any gas which start with C will have 6 in them. So CO2, right? You breathe in oxygen, you give out carbon dioxide. You breathe in air, again you give out carbon dioxide. So 1 6 and 2 6 will have carbon dioxide. 3 6, these are all your unnatural gases, right? 3 6 is cyclopropane. Any gas which start with C will have 6 in them. So 3 6 is cyclopropane. Entonox, Entonox. It is a 7-lettered word. Entonox. 7-lettered word, right? So it is 7. Pin index of Entonox is 7, right? So what is left out? Helium or heliox. It is 2 4 and 1 4. Clear? Exactly correct. Next question on your screen. Blue pipeline in OT is for which anesthetic gas? Blue pipeline in operation theatre is for which anesthetic gas? Not just operation theatre, anywhere in the hospital. Whenever there is this blue pipeline that you see running around in the hospital all throughout, what is the anesthetic gas which is present in that? Blue pipeline in operation theatre is for which anesthetic gas? Neela, yes, remembered again, Neela. So these are the various pipelines that you are able to see. Yes, see, it is not just necessary that always cylinders would be asked. Now they are even asking about pipelines, and this is a previous year question again, right? So this is your blue pipeline. It is for nitrous oxide, right? Now guys, tell me, what about the yellow one? The yellow pipeline represents what? What is it carrying, or what it is used for? Yes, Alia, Success, Yashasvi, Revati. Yes, guys. Exactly correct. Yellow is for vacuum. Yellow is for suction or vacuum, right? Yellow is for suction or vacuum. What about white? What about white pipeline? Yes, Alia, Revati, Yashasvi. Yes, all of you are correct with vacuum. Well, now what about white color? White is used for what? Blue, nitrous oxide. Yellow, vacuum. White, yes, white is for oxygen. So what is left out? Black is left out. Black is for air, right? So what is left out? Black. Black is for air. Oxygen is white and black is air. So blue pipeline in OT is used for which anesthetic gas? That is oxygen, right? Air we have just seen, it is black. Sorry, blue pipeline is for nitrous oxide, right? Oxygen is white, vacuum is yellow, right? So correct answer for this question is option C, that is nitrous oxide. Everybody clear? Clear, everyone? Moving on to the next question. A patient is in ICU and the patient is on ventilator. Hemodynamically, he has signs of poor perfusion, right? What would be the best way to increase oxygenation? Increase the FiO2, increase the respiratory rate, increase the flow rate, or increase the PEEP. P means positive end expiratory pressure. PEEP. Positive end expiratory pressure. Positive end expiratory pressure. A patient is in ICU on ventilator. Hemodynamically, he had signs of poor perfusion. What would be the best way to increase oxygenation? Yes, success says it is A, that is increase FiO2. Yes, what about other people? Alia, Yashashvi, Revati. Yes. See guys, all of you are present, please give the answers, because right now when you give the answers, it is better to commit mistakes now than to commit in the exam. Right? How much is the FiO2 that we are breathing now? FiO2, that is fraction of inspired oxygen, right? How much is the oxygen that we are breathing now? Not to worry, this is where we will like come up and make your concepts clear, right? What is the amount of oxygen that we are breathing now? Yes, just interact then, right? Just interact and try and give as many number of answers as much as possible. All right, Yashashvi, we are breathing at 20%. If we take round about 20% is the oxygen which is present in air, right? Out of total air that we are breathing, 20% of that is oxygen, right? And what is our SpO2 saturation with that? It is around 100%, I can say, right? 95, 96, 97, whatever it is, right? But what happens when the SpO2 starts to fall down, right? When the saturation becomes 85, right? Like in COVID scenarios, what did we do? How do we increase the oxygenation of the patient? What is asked? Oxygenation is asked, right? So how do we increase the oxygenation of the patient? It is by two methods, right? Either it is by increasing the FiO2, that is from 20% oxygen, you increase it up to 100% oxygen, right? Or by increasing the PEEP, or by increasing the PEEP, right? Or by increasing the PEEP. These are the two methods of increasing the oxygenation, right? Now, what do we mean by PEEP? What do we mean by PEEP? It is positive and expiratory pressure. That is what we spoke about, right? It is positive and expiratory pressures, right? It is like your balloon, right? In the alveoli, what happens at the end of expiration? Your alveoli collapse, right? But what happens when you are giving positive and expiratory pressure? They do not collapse beyond a certain point, right? At the end of expiration also, there is a certain amount of pressure which is being provided, right? So what does it lead to? It leads to increase in intrathoracic pressure, yes, which causes decreased venous return, which causes fall in blood pressure, right? Which causes fall in blood pressure, right? So can we keep PEEP in hemodynamically unstable patient? No, because already the blood pressure is low. On top of that, when you give PEEP, the blood pressure will fall down more, right? So what can be done additionally? We can increase the FiO2, right? So here what is happening? The hemodynamically patient is showing the signs of poor perfusion. That means the blood pressure is already on the lower side, correct? So out of the two options, that is increase FiO2 or increase PEEP, PEEP is ruled out. Why? Because of the hemodynamic instability. So what is the correct answer here? Increased FiO2. Clear, everybody? Yes. Now what about the two options which are left out, that is increase in respiratory rate and increase in flow rate? This will help you in assisting of ventilation, right? Oxygenation nahi, but they will improve ventilation. Clear? Oxygen is the delivery of oxygen to the tissues, right? Ventilation is your lung function that is going on, right? So which is the best option here? We will increase the FiO2. All right, got this, guys? Got this question? Any doubt? Just give me a quick nod in the comment section if you understood this question. All right, moving on to the next question. Airway resistance to flow of gases through the endotracheal tube is due to diameter, curvature, length or material of the tube, right? Diameter, curvature, length of material of the tube. You see that the airway tube is something like this. That is your endotracheal tube, right? With this end is beveled in. There is this Murphy's eye. Then there is this blue opaque, radio opaque line. And one thing that is popping out from here, that is known as pilot balloon. And this is the universal connector which connects the patient to the ventilator. All right. So airway resistance to the flow of gases through the endotracheal tube is due to diameter, curvature, length or material. Just take up this two pipes again, right? There is a water flowing through this pipe, right? And there is water again flowing through this pipe. Which one do you feel will have more resistance, right? Will this pipe have more resistance or the smaller pipe will have more resistance, right? Option A, most of you are telling that is diameter, right? So the more is the diameter, as we have spoken about pressure, right? Same way we will speak about resistance. The more is the diameter, the less is the resistance, right? The shorter or the smaller is the diameter, the more is the resistance, right? In fact, if you see, the resistance is actually inversely proportional to the power of 4 of radius. That means if the radius reduces by 1 time, the resistance increases 4 times. You're getting it? If the radius of a tube reduces by 1 time, the resistance increases 4 times. That is how it is, right? So first is the correct answer, that is resistance is directly proportional to the diameter, right? Indirectly proportional. The more is the diameter, the less would be the resistance. The less is the diameter, the more would be the resistance. So it is inversely proportional. Got it, guys? Option A, that is diameter. Correct. Which is constant here? In most of the tubes you will see curvature would be same. Length, particularly in adults, it is more or less same. In children it varies little bit. Material of the tube, always it is same, it is PVC, right? So the constant which are there, that is length, material and curvature, also it is most of the times constant. If you are using that polyvinyl chloride endotracheal tube, then you will get curvature also constant. So only thing which is changing in the tube is diameter, right? So you will use a specific internal diameter tube in children, a specific internal diameter tube in adult. All right. Next question. A patient with following ECG has reported with syncope, right? Has reported with repeated syncope. What is the management? Atropine, pacemaker, antiarrhythmics, or dopamine? Yes. ECG. Remember your ECGs. A patient with the following ECG that you are able to see on the screen, right? First of all, let us diagnose and let us understand what is this ECG showing us. Yes, whether this is a complete heart block, incomplete heart block, type 1, type 2, Mobitz wala, or whether this is your typical bradycardia, tachycardia, or whether it is a normal ECG, right? What is the ECG showing us? Yes, anytime whenever you see a ECG, what do you see? You first look at the typical things, that is the waveform, whether PQRS waveforms are present or no, right? Are they present here? P, QRS and T, right? All the waveforms are present here, right? So PQRS, everything is present. Now let us look at the rate. What is the rate here? Large square कितना है? 1, 2, 3, 4, 5, 6, almost 6 to 7 large squares. So rate is in the range of, yes, we divided by what? 300 around, right? If we divide 300 by 6 or 7 for that matter, the rate would be around 42 to 50 beats per minute, right? The heart rate is 42 to 50, right? Around 50 or less than 50 we can say, right? So whether this is normal or abnormal, what is the normal heart rate? What is the normal heart rate? Around 70 to 80, right? If we take normal heart rate around 80 beats per minute, right? So here the heart rate is in fact less than 50, right? So will we call it, what will we call it? We will call it bradycardia, right? We will call it bradycardia, right? So do we have to treat bradycardia all the time, guys? Do we have to treat bradycardia all the time? Sometimes you will see in athletes heart rate of 50, heart rate of 60 is there, which is normal, right? That is known as physiological bradycardia, right? But whenever the bradycardia is symptomatic, that means it is showing symptoms. What symptoms are being shown here? The patient is having repeated syncope episodes, right? What are the other symptoms that you will see? Patient will have repeated syncope episodes, right? This is one of the reasons. Patient might have MI, patient might have angina, right? Patient might have other vascular insufficiencies, arrhythmias, right? So whenever the bradycardia is symptomatic, we have to treat it. Whenever bradycardia is symptomatic, we have to treat it, right? So what is the treatment of bradycardia? One very important IV treatment, what we give? IV atropine, anticholinergics, right? What will it cause? It will cause increase in heart rate, right? We will give IV atropine, right? But can we continuously give IV atropine to the patient? Yes, for that we'll have to make the patient admitted in the hospital and we have to monitor the patient continuously, right? So this is a temporary treatment that we can give, right? Abhi bradycardia ho gaya, give IV atropine and observe, right? Next, what is the treatment for symptomatic bradycardia or bradyarrhythmias? Yes, what can be done for symptomatic? We can do a temporary or transcutaneous pacing. We will attach the pads on the cutaneous surface of the patient on the chest and we will send signals from there which will pace the heart, which will send pacing, which will electrify the heart, and your SA node and AV node will start functioning and it will increase the heart functioning, right? So temporary or permanent pacing, that is transcutaneous. Then there are something known as permanent pacemaker, that is also known as IV pacemaker or intravenous, that we go from your IV route, we put the pacing tubes, pacemaker subcutaneously, and we put the pacing tubes from that IV route, that is from your SJV, superior vena cava, SVC, into the ventricle. From there the pacing happens, right? So whenever there is a symptomatic patient who's showing signs of bradycardia, the best and confirmatory treatment or definitive treatment is permanent pacemaker. Clear everybody? Yes. The last option here is dopamine. What is dopamine? What is dopamine? It is a chronotropic agent. Yes, all of you have read inotropes and chronotropes. Inotropic agent and chronotropic agent, right? Inotropic means they will increase the contractility and they will cause increase in blood pressure, right? Whereas chronotropic means increase the heart rate, right? They will cause increase in heart rate, right? So chronotropic, one of the examples here is dopamine, right? It is a chronotropic agent. It can also be used, but it is a temporary arrangement. So whenever the patient is symptomatic and there is a sign that we have to manage, we will always prefer definitive management, right? Once the other causes are ruled out, yes, once the other causes are ruled out, it is not physiologic, patient is showing symptomatic symptoms of that, it is not because of MI, it is not because of coronary insufficiency, angina वगैरह नहीं है, then you will go with permanent pacemaker, right? IV, right? IV, we will place the permanent pacemaker. Clear everybody? Next question. A 50-year-old female is brought to ER in an unconscious and unresponsive state. On examination, the carotid pulse is absent. What shall be the correct sequence of resuscitation? A, B, C, C, B, A, C, A, B, or B, A, C. Remember, A stands for airway, B stands for breathing, and C stands for circulation. C stands for circulation, right? A 50-year-old female brought to ER in unconscious and unresponsive state. On examination, carotid pulse is absent. What shall be the correct sequence? ABC, CBA, CAB, or PAC? Revati, Yash, very good. What about success? Yashashvi, other people? What is the correct sequence of resuscitation? Two things. Patient is unconscious, unresponsive, right? Carotid pulse is absent. That means you will start with CPR, right? We will start with CPR, right? What is the correct sequence of CPR? Yes, it is CAB, right? Earlier it was ABC, now it is CAB. C stand for chest compressions. We will start with chest compressions first, then we will maintain or manage the airway, and last we will give breath to the patient. Last we will give breath to the patient. All right. Along with this, there is one more question which comes: what is the correct sequence? Yes, whenever you see a patient who is unconscious, what are the first few things that you will do? Right, you are there in a party and suddenly a patient becomes unconscious. What will you do first? Yes, what will we do first? What will we do first? We will call for help, we will start CPR, or what? We will check for scene safety. Right, we will check for scene safety. Scene safety for whom? Yes, it is scene safety first. Scene safety for whom? For victim or for rescuer? For both. For victim as well as rescuer, we will look and we will check for scene safety. Right. Second, we will call for help. Right. Third, we will check for responsiveness, whether the patient is responsive or not. How? We will tap the shoulders, we will tap on the cheek. Now these two, option 2 and 3, are interchangeable, right? It is simultaneously which happens, right? We are checking and we'll tell, Are please call somebody for help, right? That is how it goes. We will tap on the patient shoulder, we will tap on the patient cheek, and we'll say, uncle, hello uncle, are you able to hear me? If we know the patient, will say, Mr. X, Mr. Y, please respond, are you able to hear me out, right? So that is how we check for responsiveness and call for help, right? Last one is, we will check for pulse and we will check for breathing, right? If pulse and breath are not present, we will start with CPR, as is the case with this particular question, right? And what is the correct sequence of that? We will start with chest compressions, maintain the airway, and last we will give mouth to mouth breath. Clear, everybody? Is the initial sequence of CPR clear? Right, everyone? Next question coming up your way. I hope the ECG is visible. Now it will be. Yes. An unresponsive patient in ambulance, when attached with monitors, showed the following rhythm. Right? What is to be done next? Check for pulse and breath, chest compression and defibrillation, patient in lateral position, or cardioversion. What we will do? Yes, give me your answers. Are you able to see the ECG now completely? Alright, I can see that everybody of you are able to see the ECG now. We have started to get cardioversion is one option. Yes. What about next? Whether we'll put the patient in lateral position, we'll start with chest compression and defibrillation, or we will check for pulse and breath. Yes, patient is unresponsive, right? Ambulance is being called for. Remember the 4 steps. First one was scene safety, call for help, check for response. Yes, patient is been called, ambulance is called, that means call for help is done. Response is not there, patient is not responding, right? They have checked for pulse and rhythm, right? What is to be done next? They have checked for pulse and rhythm also, right? In the ambulance now, what is happening? They are taking the ECG, right? In the ambulance, what is happening? They are checking the ECG. That means from your basic life support, it is now gone to advanced cardiac life support, right? So first is CPR was being done, right? What is the correct sequence of CPR? C, A, B. We have just seen the correct sequence of CPR was CAB. Chest compressions were being given to the patient, right? The call for help has been answered. What has come here? Ambulance has been arrived, and what have they done? They have taken the ECG, right? In an unresponsive patient who is receiving CPR, you have taken the ECG. You will get 2 types of rhythm now, right? You will get 2 types of rhythm which are shockable and rhythm which are non-shockable, right? In which you can give the shock, in which you cannot give the shock, right? So which are the shockable rhythm, guys? Come on, quick, in the options, which are the shockable rhythms that we know of? Which are the shockable rhythms? VF and VT, right? VF and VT. So which are the shockable rhythms? VF and VT, right? Which are the non-shockable rhythms? Which are the non-shockable rhythms? Pulseless electrical activity and asystole. These are the two non-shockable rhythms, right? So first is VF and VT. These are shockable rhythms. That means whenever we encounter such rhythms, first thing that we have to do is deliver the shock, right? First thing that we have to do is deliver the shock, right? So what is this rhythm, guys? In your comment section, what is this rhythm? This is nothing but this is your VF, ventricular fibrillation, right? We should be able to read basic ECGs, right? Bradycardia, tachycardia, STT changes, broad or wide QRS complex, and your VF and VTs and asystole, right? These are the 5-6 basic ECGs that you should know, right? If you know this, along with that, the types of block, complete heart block, type 1 or type 2, all those things, right? So only this 5, 6, 7 ECGs, if you know, that is more than enough. You will be able to diagnose 80 to 90% of the ECGs in your exam. All right. The rare things are asked rarely, so not to worry on that. All right. Yes. So this is a shockable rhythm. It is a VF. Yes, it is showing ventricular fibrillation, right? So chest compression was already going on. Whenever you encounter a shockable rhythm, the first thing that you should think of is now to deliver shock as soon as possible, right? Pulse and breath has been checked. Why? Because this was done in your basic life support protocol. Now the ambulance has already arrived and they are taking ECG, right? So this is not the option. Patient in lateral position. When we will put the patient in lateral position, that is a convalescent, that is recovery position. No need for that. We have to do active management in this patient. All right. And cardioversion. Cardioversion is done when we will look at the ECGs as well. It is coming up in some couple of questions, right? Cardioversion and defibrillation. Most people are confused between the two. We will solve that as well. All right. So correct answer here is option B. That is defibrillation and chest compressions. This is the what we have to do, right? Particularly defibrillation. Correct. Everybody got this? Now, the same patient, you are giving CPR, right? The number of chest compression in adults per minute is 80 to 100, 60 to 100, 100 to 120, or 120 to 200. Yes? What is the number of chest compressions in the same patient that we have to give whenever you are giving CPR? That was the adult patient that we have seen, right? All of you have given correct answers, that is 100 to 120. Now instead of adult, now that is a 6 months old child, right? What will be the number of chest compression that you will give, right? Adults, everybody has scored brilliantly. Now it is a 6-month-old child or 6 months old baby. What will be the chest compression that you will give? 80 to 100, 60 to 80, 100 to 120, or 120 to 200? Again in the comment section, guys. In a 6-month-old child, what is the number of chest compression that we will give in that particular child? That is 120 to 200 is what yes says. Yes, everybody. Manasa, Vishal, Bio, Boosters, Success, Revati. Option B, that is 60 to 80. Okay. Forget about 6 months. Now the child is 9 years old, right? Now the child is 9 years old. How many chest compressions per minute will you give? Again, the options remain the same. 80 to 100, 60 to 80, 100 to 120, or 120 to 200. Revati says 80 to 100, or no, 100 to 120 is what we are getting the answers now. Okay, now instead of child, it is a 90-year-old female, right? Old age, 90-year-old, बहुत ही बूढ़ी बुढ़िया है, right? 90-year-old female, how many chest compressions will you give in that CPR? 80 to 100, 60 to 80, 100 to 120, or 120 to 200? Yes? All right. So whether it is adult, whether this is child, or whether this is infant, right? the number of chest compressions in all the cases will be same, that is 100 to 120 per minute, right? Whether this is adult, whether this is child 9-year old, whether it is infant, whether it is 6 months old, whether it is 1 month old, whether it is newborn, your chest compression rate is always same, that is 100 to 120 per minute. It is universal, right? It is not less than 100, not more than 120. Clear everyone? No change, no change, no change. Yes, the change has come in terms of your ventilation just last year 2019, I believe 2019 or 2020 update with CPR, but not with compressions, right? It is always same, adult, child, infant, same. Okay, everybody clear so far? So I hope and I believe everybody of you have done well so far. All right, any doubts with regards to whatever we have completed? Yes, so if you look at the number of questions, guys, we have taken all the previous year's questions, if you see, right? And I'll tell you some of the very important questions. One is your regional anesthesia, that is your local anesthetic also will be included in that. The emergency room scenarios like your CPR, right? Very, very, very important things, right? Even when it comes to your capnography or anesthesia machine, right? When it comes to your capnography, anesthesia machine monitoring parts, very, very, very important, very, very, very important parts, right? Also, from the perspective of drugs in anesthesia, we have seen that IV sedative hypnotics and all those things. It is in general, that is your IV inhalational, right? So these are some of the very important core topics in anesthesia. And since last 2 or 3 years, the examiner is very fond of COVID because that was going on. All right, whether it will be continued, whether it will be not, we don't know, right? Whether the questions will be asked or whether the question will be stopped from here on, we don't know. But make sure that all these topics are the one that you have covered and that you will cover, right? So previous year's question, if you take up, you just don't have to study that, you have to study around that. All right, so I hope you guys are doing well and are little bit motivated and boosted and are feeling that you are there on the right path and you will clear. Right now what will matter is your attitude for the exam, right? Cold is there but not much. Yes, drugs are confusing. Yes, therefore you have to revise the drugs just 1 day prior to exam. All right, so I hope you are all there on the right path. I wish you all the best for your exams. This is your host, your mentor, your educator signing off for the day, guys. Bye bye. Take care. Stay blessed. Stay disciplined and stay motivated. I'll see you on the other side of the exam. Till then, all the best and make sure you give your exam with the peaceful mind, right? Don't go there with an anxious mind. Take deep breaths. Be there and know that whatever is going to happen for the best, right? Go with that pleasant mind and attitude. All right, happy Makar Sankranti, happy new year, and wish you all the best for the exams as well. Bye bye guys, take care, see you.